So good evening, everybody, and welcome again to the ICS webinar series. And with the huge success of the previous webinar, I should be thanking the President, Dr. Sandeep Salvi, the Chair TEI, Dr. Amita Nene, and the Secretary of ICS, Dr. Raja Dhar. With this, we have our ILD webinar series. And for today's webinar, we have sarcoidosis, the great mimic. So to chair this and to act as a moderator, I'll be asking Prashant Jhaje to be the moderator of this session. And Prashant is a very good friend of mine, and we can add any adjective on him. He's the pulmonary king, the IP king of Maharashtra, and also broadly in India. He is heading the Fortis of Mumbai and the Lilavati and the Nanavati Hospital. And with this kind introduction, I will be asking Prashant to take over the session and proceed further.
Thanks a lot. Thanks a lot, Niril, for this very kind introduction. Thank you very much, ICS, for this opportunity for me to moderate this such an important topic, which I'm, sure and looking forward for a learning session for myself. And thanks a lot to to Sandeep Salvi, to Amita Nene, Raja Dhar, Indranil, who's also the governing body member of the Indian Chess Society, for inviting me to moderate this session. So, as we are already aware that this is an ILD webinar series. It's the topic for discussion today is sarcoidosis, the great mimic, and I think over the last years, when we were in medical school, we found that we were told that sarcoidosis is a disease of the West, and obviously that's a myth. And with time, we have seen over the last few decades that we are identifying sarcoidosis more. It's being, yes, it's a great mimic, but it's, we are it was probably underdiagnosed, so it's been misdiagnosed more. And so a lot of interest is there now, not only in the diagnosis of sarcoidosis, but also in the optimal management of sarcoidosis. So I think that's going to be the main goal today, about the diagnosis, the clinical aspects, how do we monitor how do we manage sarcoidosis, and the clinical questions which are associated with sarcoidosis. So for this, we have a fantastic panel, and from whom I'm going to learn a lot along with you all. We have today, it's a pleasure for me to introduce Bhavin Jankaria. Bhavin Jankaria is a very dear friend and colleague. Bhavin has been taking radiology clinics for us ever since we were at Sion Hospital, and he continues to teach us every day. Every patient we refer to him, and he gets back to us with the reporting and discussion is always a learning. So for me, it's been an amazing journey as far as learning from Bhavin is concerned about thoracic radiology. And that's going to be the first talk. The second talk is going to be by our very senior colleague and friend, Professor Dr. 𝐿.K. who's the head department of pulmonary sleep and critical care medicine at Primus Super Specialty Hospital, New Delhi. He's the former director and professor of pulmonary medicine at the Vallabhbhai Patel Chest Institute. He's a former head of the Department of Pulmonary Medicine, Faculty of Medical Science at the University of Delhi, editor of the Indian Journal of Chest Diseases and Allied Sciences, the associate editor of the Indian Journal of Allergy, Asthma, Immunology, and section editor for Lung India, and many more such academic and clinical research accolades to his credit. And above all, he is a fantastic teacher. So first, I would like to invite Dr. Bhavin Jankaria to initiate his talk. And Dr. Bhavin Jankaria will be speaking about imaging in sarcoidosis. Over to you, Bhavin.
Hi, this is Dr. Bhavin Jankaria, and today I will be speaking to you for the next 17, 18 minutes on the imaging of sarcoidosis, predominantly CT scan based. I'd like to thank ICS and CIPLA for giving me this opportunity. And this is the plan today. We look at signs, diagnosis, and staging. Then we look at stage 4 disease and other patterns. We look at sarcoid TB complex, and we look at other complications and then some practical issues. Now we know the scadding stages, right? We have stage 0, 1, 2. They're all pretty much listed here. And these have stood the test of time, and you can prognosticate based on this. And the same radiographic staging can pretty much be used with CT as well. So let's look at stage 1, where we see non-necrotic lymphadenopathy. The classic pattern on CT is subcarinal bilateral hilar enlarged lymph nodes. This may be asymmetric, and necrosis is rare. Now, long-standing cases may show calcification, including eggshell calcification, and we see the lambda sign on PET-CT. So this is that typical pattern that I just showed you. But you can have a large subcarinal hilar lymph node here. There's no left hilar adenopathy, and then the patient improved with treatment partially about 6 months later. Similarly, here we have a patient with subcarinal right hilar, but the largest lymph node is the paratracheal lymph node, and then everything's improved a few months later. A colleague of mine in 2017 had this published, where you see these tiny hypodensities within the enlarged lymph node, and this is called the cluster of black pearl sign. Unfortunately, this sign has never been replicated, and we don't really use it in practice. You can have associated abdominal retroperitoneal lymphadenopathy. Again, this is a slightly unusual pattern. We also have splenic lesions. So this suggests granulomatous disease. You have to rule out lymphoma. You have to rule out tuberculosis. And so I biopsied the retroperitoneal node, and this was non-caseating granulomatous disease, and the patient responded to sarcoid treatment. Now, in long-standing cases, we can see eggshell calcification, as you see here, best appreciated on the plain scans, the ones without IV contrast, because here you might think that this is enhancement. And so it's always a good idea when there is lymphadenopathy to look at the plain scans. On PET-CT, again, you can see the classic presentation, non-necrotic subcarinal bilateral hilar. But then when you look at the distribution of the uptake on the coronal MIP images, it has this lambda sign, which you sometimes have to imagine a little bit, but it's there. Stages 2 and 3 are when you start seeing lung lesions. So stage 1 is purely lymphadenopathy. Stage 2 is lymphadenopathy with lung lesions. And you can see here the classic fissural and perivascular nodules. And stage 3 is when you don't have lymph nodes, or the lymph nodes have started going away or regressing, but you have these lung lesions, again showing a peribronchovascular distribution. So the lung lesions present as small nodules. Here you see the fissural perivascular beading, septal subpleural with coalescence and these different signs, or they may be large nodules, or they may present with ground glass. And so the classic presentation is when you have these perivascular nodules and you get the beading along the vessels. There are fissural nodules here and subpleural nodules here. Then you can again see the perivascular beading extremely well. The disease typically starts earliest in the perihilar region here. And on the coronal images, the fissural nodules are much better appreciated. And so here's a chart that I've made of different nodules, ill-defined, diffuse, scattered, and the list is entirely here. What we are right now concerned about are the discrete nodules, because they are the ones that come as differentials to the sarcoid nodules. And just to show you that, here are typical fissural peribronchovascular nodules of sarcoid versus silicosis, where we get confluent nodules of different sizes, miliary TB. We have 2 to 3 millimeter size nodules randomly distributed. Tropical eosinophilia is not discrete, and you get these ill-defined nodules of differing sizes, and hypersensitivity pneumonitis would have ill-defined centrilobular nodules, which are typically same size. So same-sized and different-sized also matter. Sarcoid will be different-sized nodules. And TB, of course, is tree and bud, where you have branching centrilobular nodules, and that's how you can differentiate these. What are the other signs? We have the nodular reverse ground glass. So it looks like there's ground glass in the center and then a nodular pattern at the periphery. Again, you have the classic lymph node pattern. So this becomes stage 2 disease. And then when these nodules coalesce, typically the larger nodules, you get these galaxy and cluster signs here. So here it's the same image that I've used in minimum IP and maximum IP projections. And again, stage 2 disease because the patient has non-necrotic lymphadenopathy. And again, we have coalescent nodules in different forms. Now, you don't always see the galaxy sign, but this is called a cluster sign because you've got clustered large nodules and small nodules getting together. Remember that these signs are not don't just occur in sarcoid, but can be seen in tuberculosis as well. This was a patient with sputum positive TB who's got the galaxy and cluster signs, but these are due to centrilobular nodules and not peribronchovascular nodules. Another pattern we see is the tumefactive pattern, the pattern that sometimes occurs with silicosis where we get progressive massive fibrosis, but you can see that in sarcoid as well. And here's this patient who's also got eggshell calcification and has these large perihilar lesions of sarcoid. You also have large nodules and you also have small nodules in the same patient. Now, when we're looking at sarcoid patients and we're monitoring them, we can often see them gravitating from one stage to another. So here is a patient with stage 1 disease, proven to have non-caseating granulomatous disease, lungs absolutely normal. And then about 6 or 7 months later, the lymph nodes have started regressing, but the lung lesions have appeared. So you could even say that, once the lymph nodes become normal sized, this actually becomes stage 3 disease. And so that's something that we can keep tracking as well. Let's look at stage 4 disease. Now, stage 4 is when we have fibrosis or a fibrotic sarcoid or chronic pulmonary sarcoid. These are the various terms that are used. And here is a patient known to have sarcoid who's developed reticular opacities with an upper lobe predominance, with volume loss, but you can also see the residual fissural and perivascular nodules in this patient. This is another presentation where we have honeycombing, but with an upper and mid-zone predominance. You can see that on the coronal images with cystic change, with traction bronchiectasis. We know this is a fibrosing ILD. We know this is the non-IPF pattern because it's not subpleural basal predominant. Plus, there is an axial distribution here. And then you have to differentiate between fibrotic HP and chronic pulmonary sarcoid. But this particular pattern of upper and mid-zone predominance with an axial distribution, and there is some fissural nodularity here, is typical of chronic pulmonary sarcoid. Here is another patient, or the same patient actually, of tumefactive sarcoid that I showed, who presented first in 19. So this is a progressive massive fibrosis-like appearance. There is some improvement between 19 and 21 as far as the perihilar masses are concerned. But at the same time, you can see the reticular opacities and the perilobular changes, some of which are permanent with the architectural distortion, telling us that there is a fibrotic component here. And the fibrotic component can progress as well. So this is Feb 14. You can see some basal honeycombing. That's your typical axial distribution. There's an upper lobe predominance here. And then 6 years later, you can see that the traction bronchiectasis has increased, the upper lobe fibrosis has increased. So there is gradual progression, but it does occur, and we're seeing it here. This is a 41-year-old in 2005 with biopsy-proven sarcoid, and in fact, discussed it in detail at this particular site here. And you can see mildly enlarged lymph nodes. This patient had a focal coalescent consolidation, which I did a CT-guided biopsy on, and it showed non-caseating granulomatous disease. In 2006, the patient's lymph nodes had regressed. Then the patient had developed these multiple nodules in the lungs, but the consolidation had regressed. And in 2020, the patient now has stage 4 disease, where you have this perilobular reticular opacities, there's some ground glass, there is traction bronchiectasis, etc. Now, if the patient had come in only in 2020, we would have said this is a non-IPF fibrosing ILD and likely suggestive of fibrotic HP, because we also see what looks like a triple density sign. There's ground glass, lucent lung, and let's say normal lung here, right? But even the triple density sign can occur in other conditions. And here we can see that it's occurring in a patient with sarcoid. And this is why old scans matter. We tend to disregard the importance of comparative scans. Very often the patients also think that what is the point having all of these things available? They sometimes are so upset when we ask for old scans. We've had negative Google reviews given to us because they think that we're going to copy paste the report from before, all kinds of stuff. And I think maybe at a physician level, it's not a bad idea every time that we get a patient with diffuse lung disease to ask them a simple question. Did you ever get a CT scan done in the past? Whether it's even 20 years ago, because it completely changes the picture and our ability to interpret. And remember, during COVID, half India's population was asked to get CT scans done. So if nothing else, we would at least have scans that are 3 or 4 years old now at this stage. There are other manifestations as well. And here is, again, somebody in 2005, 51 years old at the time, typical sarcoid. You've got peribronchovascular nodules, axial distribution. You can already see there's a fibrosing component with traction bronchiectasis here, biopsy proven. And in 2022, 17 years later, has presented with this extensive cystic change. Now, if you saw the patient only in 2022, you would wonder what kind of cystic lung disease this is and start thinking of a bunch of other possibilities. But this is just sarcoid, where you have reparative cysts here, which have developed as part of the fibrosing process. And that is known. Occasionally, you'll get a fibrotic HP also that presents like this with cystic change here. But this is the same patient presenting with cystic change. We also have an indeterminate non-IPF pattern, right, which can be a presentation. So this is a 51-year-old in 2021. You can see that there's ground glass, little bit of traction bronchiectasis, there's some amount of cystic change or honeycombing here. There's an axial distribution from hilum to the periphery. So it is a non-IPF pattern. Looks mixed. There is a fibrosing and a non-fibrosing component. And typically our first diagnosis would be hypersensitivity pneumonitis in India. But the patient underwent a biopsy. The biopsy showed sarcoid. And in a multidisciplinary meeting in another country, they confirmed this diagnosis. However, you can see here the progression. So this was March 21, and from 21 to August 22, you see that the traction bronchiectasis has increased at the same level. And then another level here between August 22 and September 23, where there is progression of fibrosis again in the lower lobe. So even now, even at the end here, it looks like it could be hypersensitivity pneumonitis, but this is another presentation of sarcoid that is known, and that is looking like HP. So it presents with ground glass rather than nodules, and it can be difficult to make the diagnosis, and sometimes the only way to do that is with a biopsy. Then, of course, we have the sarcoid TB problem. Here is a 35-year-old with cardiac and nodal sarcoid, biopsy proven. I showed this case earlier when I showed this large paratracheal lymph node. The nodes improved on steroids, but then the patient developed lung lesions, and I'll show you the lung windows as well. Then eventually there was post-obstructive change and pleural thickening because of pleural effusion, etc. So these are the lung windows, absolutely normal in 2017 November, classic coalescent lesions, consolidation, a tree and bud appearance, etc. And then here there's destruction in the right upper lobe, and there was pleural thickening. And I'll show that again, right? So here are the the mediastinal lesions, lymph nodes, improved lung and pleural pathology, and that is the lung component. We can get other complications. This is a patient known to have sarcoid. You can see the appearance here in May 21 and November. There's some progression here, in fact. And here is the cavity. You see a fungal ball here. And so these are cystic lesions because of the fibrosis, one of which has got infected with a mycetoma or a fungal ball, and that fungal ball has increased by November. Sometimes they're not even picked up during the reporting, and then the patients keep lingering. And what I do teach my observers and residents is that and fellows rather, is that whenever you're looking at a fibrosing ILD, whenever you're looking at comparative scans, one of the things to look for is a superadded complication, and then one of them is a fungal ball. A practical issue in India is when you have a patient who presents like this with symmetric non-necrotic bilateral hilar and subcarinal lymphadenopathy. We're often at a loss. You have to do a nodal biopsy, and even then, if the diagnosis is non-caseating granulomatous disease, it becomes a little difficult to know still whether it's non-necrotic TB versus sarcoid, and there are issues. Now, as radiologists, and even as physicians and pulmonologists, you need to pay attention to the lungs in a little more detail. So this was reported normal or non-specific, but if you look at the lungs here, you're actually seeing fissural and perivascular nodules here. And look at these are discrete nodules. You can see them separately, and they're along the fissure. Now, if you look at the coronal images, you can actually see that they are fissural nodules. And remember, I said that the coronal and sagittal images allow us to see these nodules better. And look at this area of coalescent nodules along the major fissure. And I've used minimum IPs and maximum IPs and all of that to show these nodules better. And this is classic sarcoid, right? So you have this, and it all changes. So you have a patient with non-necrotic adenopathy, you're not sure, and then you look at the lungs and you see this. Now you're sure that you're dealing with sarcoid. And the same happens with TB. We have necrotic adenopathy, tree and bud. Then we can confidently say this is tuberculosis. We have lymphadenopathy with eggshell calcification, and this pattern of disease with progressive massive fibrosis and coalescent nodules. Then we can confidently say that this is silicosis. And if we have a patient with septal thickening, what is a lymph node here, but in the presence of cardiac failure, etc., you can get mildly enlarged lymph nodes because that's part of the what would I say, volume overload, and often the lymphatic obstruction, etc., which produces these mildly enlarged lymph nodes, and we shouldn't mistake this for disease. So that was the plan today. We've looked at signs and diagnosis and staging. So here we've looked at the SCADing classification system or criteria from 1 to 4, and how the system that was developed for X-rays translates into CT as well. Then we've looked at stage 4 disease in terms of fibrosing ILD. Remember, about 20% of patients with sarcoid land up with chronic pulmonary sarcoid. Sometimes the presentation is directly as a fibrosing ILD because all of the earlier stages were missed. And then we have the other patterns as well, where apart from presenting as nodular disease or with lymphadenopathy, you can also have a presentation with ground glass and looking like HP. Then we've looked at sarcoid TB complex and other complications, and the practical issue of looking at the lungs when you have lymphadenopathy. I did a series of lectures about 3 months ago. These are all free. They're all available at these URL. You just go to ctchestreview.com and you'll get them there. That's my WhatsApp channel where I put up regular updates on everything that I'm doing once a day or once in 2 days. I cannot but plug my new book, which is available on Amazon, and then the CT-ILD book, which many of you already have or have read, which is also available on Amazon. Thank you so much for listening to me, and I hope you have a great meeting. And again, thank you, ICS and CIPLA and T.
You are on mute.
Dr. Prashant is on mute.
Okay. So sorry again. Yeah. So thanks a lot, Bhavin, for this excellent talk. And as I was saying, as usual, Bhavin is so clear, crisp in his communication, in his presentations, and also there's always something to learn, always, whenever we listen to Bhavin. And, I just want to tell the audience that before we move on to the next lecture, I'm really thankful to CIPLA for taking this entire ILD web series and particularly today's talk to the larger, to over the country, to all the doctors. And I'm very happy to say that as of now, as we are discussing, we've got 1,703 live participants online. So thanks a lot, CIPLA. Thanks a lot, Harshal, for your effort to take this to as many doctors as possible and for increasing the reach. Now we move on to the next lecture, which is also a very important lecture. We know CT scan forms the imaging forms a very important role in the diagnosis and the management of sarcoid. And now to give us an overview on this important topic, we have Dr. S.K. Chhabra. I already gave you an introduction. Fantastic clinician, orator, researcher, and a very well-respected doctor. And he'll be speaking to us on the diagnosis and the management of sarcoidosis over the next 20 minutes. Thank you so much, Professor Dr. Chhabra.
Thank you, Dr. Prashant, for nice words of introduction. And at the outset, I would like to thank the ICS team and especially Dr. Amita Nene for giving me an opportunity to come here and share my thoughts about sarcoidosis. So we have heard a brilliant presentation by Dr. Jankaria on the radiological aspects. And now I'm going to take, just let me get my slides on. Right. So now from looking at sarcoidosis from a clinician's perspective, how do we diagnose and how do we manage? Now, I would like to straightway tell that what we talk about management has very little evidence to support. Even today, after decades of research, we don't have very good clinical trials. So all our recommendations are largely a consensus or a little bit from some case reports or small series of trials which have been done. So solid database on evidence is lacking. Nevertheless, as pulmonologists, we always approach and treat sarcoidosis with a gut feeling, and the more experience you get, the more sure you are of the diagnosis. So what is sarcoidosis? It's a multi-system disorder, which means not only lungs, but other systems are also involved. And we often get referrals from especially our eye colleagues or cardiologists or neurologists about sarcoidosis, and very often they leave the treatment to us. It's a disease of unknown etiology. Lots of work has been done, but still no cause found. And the characteristic pathological feature is a non-gazetting granuloma. It's more of a description that forms the definition of sarcoidosis, mostly affecting young adults. And to a pulmonologist, characteristically presents with reticular opacity in the lungs with bilateral hilar lymphadenopathy, lots of CTs that we have just seen in Dr. Jankarya's presentation. Besides lungs, eyes, skin, and joints are very commonly involved, but practically every organ of the body, and especially heart, kidney, CNS, reticular endothelial system may be involved. So how do we clinically recognize sarcoidosis? It has a very, very wide range of presentations, ranging from no symptoms at all, diagnosed incidentally because the patient underwent a chest X-ray for some other reason, even a medical checkup, to a crippling disease which becomes fatal for the patient. So very wide range of presentation. Usually the patient comes with persistent dry cough and shortness of breath, and usually it's a chronic presentation, has been going on for a few months or a couple of years. Unlike tuberculosis, which forms a major DD in India, constitutional symptoms are usually not prominent. Fever may or may not be there, but usually that kind of malaise, loss of appetite, loss of weight are very uncommon. Patients may have arthralgia without arthritis. Fatigue is very common in sarcoidosis. A lot of manifestations outside the lungs, so skin, lots of manifestations like nodules, plaques. Eyes, uveitis is a very common presentation. In fact, sometimes patients come with recurrent uveitis and our eye colleagues ask her whether this is sarcoidosis. Then lymph nodes anywhere in the body, joints, painful swollen joints, neurological manifestations, cardiac manifestations, very important. Patients can have a fatal termination because of cardiac. Renal involvement, renal and hepatosplenomegaly. Now, sarcoidosis can be fatal, especially when there is cardiac and neurological involvement. And of course, lungs form the major causative factor for mortality, especially when there is diffuse lung involvement and pulmonary hypertension. So sarcoidosis can be fatal or it can be just a nuisance for the patient. A few signs, especially from a pulmonologist's point of view, clubbing usually is not there. Maybe there in very advanced disease, but usually it is not there. A peculiar thing about sarcoidosis is what is known as a clinico-radiological dissociation. That is, you see a CT or a chest X-ray, it shows widespread opacities, but on examination you don't find anything on auscultation or otherwise. Signs related to extrapulmonary disease may be there. In advanced pulmonary disease, of course, the patient comes in respiratory failure, so you would have cyanosis with pulmonary hypertension, signs of corpus. So a wide range of presentation. So how do we diagnose sarcoidosis? There is a ATS document of 2020 which describes that the diagnosis is based on 3 major criteria, but it also recognizes that these criteria are not 100% specific. So at the end of these 3 criteria being satisfied, we are still not sure whether we are dealing. So a clinical judgment, therefore, is very, very important. So a compatible clinical presentation that includes symptoms and other tests, which I'll be telling shortly. Then the finding of non-necrotizing granulomatous inflammation in 1 or more tissue samples. That means that we have to obtain a tissue by different means, although it may not always be possible, and in some patients it may not be required. So we have to individualize what tissue we are going to get and whether we are going to just observe the patient or not, because not all patients would require treatment. Exclusion of alternative causes of granulomatous disease are very important. Lymphomas, tuberculosis, these form the major DD in our cases, and we have to be sure that we are not dealing with these alternative DDs. So diagnostic evaluation in such a patient, we will begin with a complete blood count, non-specific finding like anemia, leukopenia, LFTs, an elevated serum alkaline phosphatase may be an indicator of a hepatic involvement. There can be renal involvement, urinalysis. Glucose measurement is important because we are going to treat these patients with steroids, and a patient who already is a diabetic may find that his glucose control gets derailed. Serum calcium is a very important marker of disease activity, and we must look for serum calcium. There was a time when 24 hours urinary calcium was also suggested as a diagnostic tool, but more recent statements have excluded that. ESRCR proteins are non-specific. Serum angiotensin converting enzyme may help in the diagnosis, but it is neither sensitive nor specific. But if it is raised and along with other compatible presentations, one goes in the direction of making a diagnosis of sarcoidosis. Our tuberculin skin testing is useful because most patients with active sarcoidosis would have a negative MON2s. IGRAs would still be positive. A word about what is known as the 𝐾𝐚 test, especially for the younger generation who may not have heard of this test. Now, this is of historical importance. This was an intradermal test where a sarcoid tissue was injected, and after a few weeks, a nodule formed, and then a biopsy was done. So this is just to mention that how sarcoidosis was diagnosed once upon a time, but no longer done. Screening for ocular sarcoidosis is important because these patients may have eye involvement. Vitamin D measurements are useful because calcium derangement is very common, and if there is vitamin D deficiency, then this has to be supplemented. In the elderly, we have to look for presence of osteoporosis also, more from the point of view of the treatment complications. Now, what about cardiac investigations? ECG is often done as a routine, but if ECG shows some blocks or some arrhythmias picked up incidentally on ECG, then Holter is indicated, and then echo is indicated. If ECG is normal and there is no cardiac suggestion of involvement, there are no cardiac symptoms, then the ATS guidelines say that we need not go in for a routine echocardiography. But if ECG is abnormal or one is suspecting pulmonary hypertension, especially in advanced disease, or when there is a disproportionate reduction in diffusion capacity, then an echocardiography is mandatory. Then imaging. Dr. Jankaria has told us about the CT imaging and how useful it is, and certainly certain characteristic signs of sarcoidosis which help us to pinpoint the diagnosis of sarcoidosis. But imaging begins with a chest X-ray, and I'll be focusing more on chest X-ray than on CT because that has already been taken. Now, lungs remain the main site of involvement. Even sometimes when the main presentation is extrapulmonary, still chest imaging must be done because asymptomatic pulmonary sarcoidosis may still be picked up. We have different kinds of imaging modalities which we can use. For us, usual chest involvement begins with a chest radiograph and then followed by CT scan. PET CT has its utility both in pulmonary and extrapulmonary sarcoidosis, and MRI imaging for cardiac and CNS involvement in sarcoidosis. Scanning stages have been mentioned, and it is of historical importance to note that in 1961, when the CT was not there, this was the way radiography in sarcoidosis was described by scanning. So 4 stages. Presence of bilateral hilar lymphadenopathy is stage 1. Bilateral hilar lymphadenopathy with parenchymal involvement, reticular opacities. Because on a chest X-ray, we pick up limited types of opacities compared to a CT scan where very classical signs as described are picked up. Reticular opacities alone with shrinking nodes is stage 3, and reticular opacities with fibrosis, that is stage 4. Now, stages of sarcoidosis, one needs to understand that these have utility as well as limitations. These are useful because they suggest a diagnosis, and so one can initiate investigations towards confirmation of diagnosis. Chest X-ray is very useful in follow-up because one cannot go on doing CT scans again and again. So a follow-up usually is done with a chest radiograph. In general, patients would progress in their natural history from stage 1, 2, 3, and 4. However, these stages do not correlate particularly well with clinical severity. So we can have patients presenting with stage 2 very symptomatic, patients presenting with stage 3 not so symptomatic. So the clinical correlation is not absolute. And one thing is has been established that greater the or the higher the stage, then the chances of spontaneous remission decrease. It should be noted that a CT staging may be different because a CT has higher sensitivity. For example, if a chest X-ray does not show clear hilar lymphadenopathy, but a CT scan may. So a chest X-ray stage 3 may be reverted to stage 2. This staging is more for diagnosing sarcoidosis than for treatment. And as I will be coming to treatment, now we don't categorize treatment or start treatment on the basis of staging, but the indication of treatment are somewhat different. So these are the classical appearances, plain radiograph, stages 1, 2, 3, 4. So stage 1 is bilateral hilar lymphadenopathy with a paratracheal lymph node, often referred to as a judge's wig appearance. Stage 2, when the lymphadenopathy is there, and then there are parenchymal opacities. Stage 3, the lymph nodes have regressed, parenchymal opacities are there. And then stage 4 is a stage where there is a lot of fibrosis, sometimes with cavity. So that is the end stage and more advanced stage of sarcoidosis. Pulmonary function tests are done both at baseline and then on follow-up. Usually we get a restrictive pattern because of the parenchymal involvement. So FVC will be reduced. However, about 10% of patients will also have an obstructive pattern, usually because of endobronchial disease or because of bronchial distortion. Airway hyperreactivity has been described, and even bronchodilator responsiveness may sometimes be noted. And these patients may have actually wheezing and may sometimes be treated as asthmatics. But an obstructive pattern is noted on sarcoidosis, which again is in contrast to other fibrosing ILDs like NSIP or IPF. Diffusion capacity is a very useful test. It is reduced along with the spirometric pattern of restriction or a mixed pattern. A 6-minute walk test is useful, especially in more advanced stages, because it shows desaturation on walking. When patients have a diffusion capacity which is reduced less than 60% and patient desaturates on walking during a 6-minute walk test, then one should suspect pulmonary hypertension and accordingly work up for that. Because the diagnosis is based on the presence of non-caseating granulomatous inflammation, so a biopsy or a cytological examination is required. Now, this histopathological sampling may come from different sites which are involved. It could be a lymph node, it could be a lung tissue, and there are different ways in which we can obtain the tissue. There is an FNAC biopsy, an EBUS is there, lung biopsy, transbronchial lung biopsy, transbronchial lung cryobiopsy. Biocytology has its uses. There was a time when open surgical biopsy or VATS biopsy were done, but now one would rarely need to fall back upon a surgical biopsy to confirm the diagnosis. So since we'll be discussing this, so I'll just go fast on this. Now, after making a diagnosis of sarcoidosis or a reasonable diagnosis of sarcoidosis, how do we treat? The ERS has come out with clinical practice guidelines on treatment of sarcoidosis published in 2021, and I am going to base my brief overview on management on these guidelines. Even they recognize that these are more of consensus and not very solid evidence based. Because it's a disease of granulomatous inflammation, so anti-inflammatory therapies remain the cornerstone of treatment. The first line treatment is corticosteroids, prednisolone or prednisone. Some patients who don't respond or they require prolonged courses of steroids, are developing adverse effects, for them we add a second-line immunomodulatory agents, methotrexate, azathioprine, leflunomide, mycophenolate, hydroxychloroquine. Patients who are refractory to first-line steroids and then immunomodulatory drugs, newer agents have been tried successfully in more advanced cases, including anti-TNF drugs like infliximab, which has good reports favoring it. Then other biologics like adalimumab or rituximab. And in very advanced cases, repository corticotropin injections are indicated. So these are the drugs that we have in our armamentarium to tackle the problem of sarcoidosis. Now, it must be mentioned that only 2 drugs are FDA approved for pulmonary sarcoidosis, prednisolone and repository corticotropin. All other drugs that we use, all these are off-label indications because the evidence is not very strong to get the FDA approval for these. Now, this statement has adopted the standard PICO format for its recommendation, the population intervention comparator and outcomes being considered. So as far as pulmonary sarcoidosis, I'm going to limit my presentation on management to pulmonary sarcoidosis. Extrapulmonary will be taking up from the audience questions and in our Q&A. So there were 2 questions for pulmonary sarcoidosis. In patients with pulmonary sarcoidosis, should corticosteroid treatment be used versus no treatment? So it is notable that there is an option of not treating these patients. Second, in patients with pulmonary sarcoidosis, should one add immunosuppressive treatment or remain on glucocorticoid treatment alone? That is, should a second agent be added? If not at the beginning, maybe at a later stage. Now, sarcoidosis treatment is not mandatory that you make a diagnosis and straightway write a prescription. Sarcoidosis is treated only when there is substantial morbidity which is affecting quality of life, or there is a danger to life. That is, there is a mortality risk. Now, mortality risk in sarcoidosis varies depending on its involvement and extent of involvement. So that is a clinical judgment, but usually in more advanced cases of pulmonary sarcoidosis who are symptomatic and therefore their quality of life is impaired, usually treatment is given. But in a patient who has been diagnosed because a routine chest X-ray showed a bilateral hilar lymphadenopathy, one may choose to not treat this patient, but only observe and have a close follow-up. So treatment is not mandatory. It's based on our assessment of what is the risk to patient's life and what is the impairment of quality of life. So the recommendation, first recommendation on treating these patients, for untreated patients with major involvement from pulmonary sarcoidosis, major involvement would mean that there is a substantial parenchymal involvement. So these are believed to be at a higher risk of future mortality or permanent disability. So the statement recommends use of glucocorticoids to improve or preserve efficacy and quality of life. Now, one should note that this is a strong recommendation, which means that go ahead and use it, but there is a low quality of evidence. For the second question, for patients who are symptomatic with pulmonary sarcoidosis at a higher risk of future mortality, risk of permanent disability, and who have been treated with glucocorticoids but have continued disease or unacceptable side effects from steroids. That is, we have started these patients on steroids, they continue to worsen or they are still symptomatic. So in these patients, the second line drugs are indicated, and usually methotrexate is the one which has been suggested, although there are other options. Now here it's a conditional recommendation and a very low quality of evidence. Then patients who, in spite of being on steroids and other immunosuppressants, if they still have continued disease or unacceptable side effects, what do we do? Then we have the option of going to biologics, anti-TNF. So infliximab has had some good reports in its favor in small studies and case reports. And this is recommended, again, conditional with a low quality of evidence. So this is an algorithm for pulmonary sarcoidosis. So it's a question of what is the risk to the patient, risk of morbidity and mortality. So more advanced patients would be considered to have a higher risk and would require a different kind of approach. So a low risk patient, that is a stage 1 patient, you just observe, keep under follow-up and just see whether symptoms are appearing or the X-ray is worsening. So the need for treatment is individualized. If we feel that it's worsening, then steroids will be added. For higher risk, steroids are drugs of choice. If these don't work, then methotrexate is the next line. Alternatives are azathioprine, mycophenolate, and hydroxychloroquine. If these don't work or patient is still inadequately controlled and disease is progressing, then infliximab is the next option, and finally rituximab. So the same approach for high-risk patients, and we go on adding drugs while monitoring the patient. Follow-up in patients of pulmonary sarcoidosis is clinical. We look for the resolution of symptoms, and the good thing about sarcoidosis management is that usually patients do respond very well, especially patients who have mild symptoms or caught up early in their disease. Lung function testing is useful to follow spirometry and diffusion capacity. Unlike NSIP or IPF, where we do not expect improvement in FVC, here a positive trend can be observed in lung function. Patients may actually show an improvement in their vital capacity on treatment. A chest X-ray is useful for follow-up because it shows the resolution patients are responding. CT cannot be done repeatedly, but maybe annually or as indicated. This would help in assessing the response to treatment. Extrapulmonary disease can be present at outset, or it may develop later on during natural history. So one should be on the watch for development of extrapulmonary disease. So finally, the prognosis. Asymptomatic patients do not require treatment and often remain stable for many years. However, those who develop symptomatic lung disease or extrapulmonary disease tend to have a guarded prognosis. Relapse of symptoms is common. Very often we see patients who have been treated for a year, they go into a phase of remission only to have a relapse of symptoms. So they keep requiring these treatment phases from time to time. And patients who develop more advanced disease may ultimately develop pulmonary hypertension. Incidentally, pulmonary hypertension in sarcoidosis is a very interesting topic, and it could be group 2, group 3, group 5, and sometimes rarely group 1 also. So wide causative mechanism for sarcoidosis, PAH. The overall mortality for untreated patients is about 5%. However, prolonged treatment with steroids is not benign. That is why other options have to be considered and side effects have to be monitored. So I'll stop my presentation here so that we can have more time for discussion and Q&A and audience questions. Thank you very much.
Great, sir. Thanks a lot, Dr. Chhabra, for this very nice, simple, and a very clear overview on the diagnosis and the management of sarcoidosis. Now, we will now move on to the next part of our symposium today, and that is the panel discussion. So now for the panel discussion, we will have, of course, Dr. Chhabra, who will stay back. And also, I would now like to invite Dr. Indraneel Haldar. Indraneel, thanks a lot for your very kind introduction. And now that's my opportunity. This is a very brief introduction for Indraneel. I must say he is a chest specialist interested in pediatric pulmonology. He's an assistant professor, Department of Respiratory Medicine and College of Medicine at JNM Hospital, Kalyani, and he's the faculty of the National Allergy, Asthma, Bronchitis Institute in Kolkata, and a fantastic human being, a very dear friend, and a fantastic clinician, researcher, academician, and very actively involved in the societal activities to promote the agenda of the society and also to promote academia and teaching activities. Indraneel, Thank you very much for joining us on this for this webinar. The next I would like to now invite to the panel is Dr. Varuna Jethani, who's an pulmonologist, also certified in tobacco cessation from the Gujarat University. He's working as an associate professor in the Department of Respiratory Medicine in Himalayan Institute of Medical Science in Jollygrant and Dehradun. Dehradun is always dear to me. My son studies there. Nodal officer in for tuberculosis. She's received a Young Respiratory Research Award, and she's presented international papers at the ERS and has 30 publications. So thanks a lot, Dr. Varuna, for joining us for this panel discussion. Next, I would like to invite my dear friend, Dr. Kumar Utsav, for this panel discussion. Can we change the slide, please? Yeah, technicians, can we please change the slide? Thank you. So Dr. Kumar Utsav, a dear friend, and also he's a consultant pulmonologist and critical care specialist at the chest clinic in Durgakund. He's a director pulmonary division at the Agri Hospital in Varanasi. He's done his MD respiratory medicine from Ahmedabad. He's accumulated a vast experience in COVID, I would say entire pulmonary medicine, including MDR, XDR, TB, and he's got numerous publications. And I must say that he had played a very important role in the organization of the NAFON at Varanasi, which was a fantastic event. So he's got, along with being a very good clinician and a teacher, he's also a very good organizer for academic and teaching events. Thanks a lot, Kumar, for joining us for this panel discussion. And lastly, I would also like to invite now Dr. Jai Mullarpattar, whom I've known for a long time, a dear friend and colleague, who is a consultant a pulmonologist at the Hinduja Hospital and the Medical Research Center in Mumbai. He's also a very good clinician, liked by his colleagues, his friends, and also by the patients. And he's a member and has got fellowship of various respiratory societies, such as the Indian Chest Society, the European Respiratory Society, and he also has a fellowship of the American College of Chest Physicians. So with that, now let's move on to another important aspect of this webinar. I think we've had two fantastic lectures on the imaging of sarcoidosis. Also, the second one was on the diagnosis and management of sarcoidosis. There's an overview. Now, what I would like to do is I would like to start again from the initial bit, from the staging, etc., and build up the discussion towards the diagnosis, treatment, and we'll also take some practical points as we go ahead. During this panel discussion, there may be some repetition, and that repetition is again in the interest of the entire audience, so that the important points are also reiterated and conveyed also from a different perspective. So, Indranil, I would like to start the discussion about, Bhavin explained about the various stages of sarcoid. Dr. Chhabra alluded to it. I would again like you to summarize the different stages of sarcoid, and and then how we. And after that, I'll go ahead. So, to initiate the discussion, can you just again tell us about the different stages of sarcoid?
So both of us speakers has clearly told about the staging of the scanning criteria for the staging of the sarcoidosis from the 5 stage 0 to stage 4. Whereas stage 0, there is a normal chest radiograph, the stage 1, hilar or mediastinal nodal enlargement. The stage 2, the nodal enlargement with the parenchymal disease. Stage 3, the parenchymal disease only. And the stage 4, the end stage, that is the pulmonary fibrosis. These are the 5 stages, which has repeatedly been told by our previous speaker. And with this, we have to classify and then plan of our treatment also.
Yeah, so thanks a lot, Indranil. I think, the reason I brought this up was that, on one hand, we have the stages of sarcoidosis, and, they may not necessarily relate to the treatment decisions, etc. That is just a staging classification. Absolutely. And now to put upon the clinical aspect of this, I would like to ask Varuna, can you just tell us whether stage 1 how stage 1 sarcoid usually presents, and what are the clinical findings and symptoms in stage 2, 3, and 4 sarcoid? So basically, if you can just take us through the clinical symptomatology to the various stages of sarcoid.
Yes, as Dr. Chabra sir has clearly told us, in the stage 1 sarcoid, it is mostly accidentally diagnosed, and it is an incidental finding on an X-ray. When we patient come for another testing, we go for an X-ray and we get the hilar lymph node. That is stage 1, that is accidentally diagnosed, and sometimes we get cough and associated constitutional symptoms may be there like malaise and fatigue. Stage 2, 3, and 4, where there is a parenchymal involvement. So we get the symptoms of cough, dyspnea, chest pain, sometimes associated with fever that confused with the other differentials, and they are associated maybe with the weight loss, malaise, and fatigues. Talking about the clinical findings, if you examine the patient, we would get the wheezing, as told by sir also. We will get wheezing that is mostly due to the endobronchial involvement, airway hyperreactivity, or any compression of the lymph nodes of the bronchus. There, in the advanced stage, we get crackles. There may be associated clubbing, and there may be a presentation of hypoxemia. And must we do is the ocular examination for the uveitis, skin examination for erythema and lupus to further confirm the diagnosis. Thank you.
So I think thanks a lot. You've really given a good overview from the clinical aspects. So we need to look, individual can be asymptomatic, or the individual can have symptoms that are related to pulmonary manifestations. You can have general pulmonary symptoms, or you could have extra pulmonary organ specific symptoms. So this is what we need to always be aware when we are thinking and suspecting sarcoid. So Kumar, I would like to ask you, what are the common extrapulmonary manifestations that one can come across? The emphasis has been played on the pulmonary symptoms. Can you just expand a little bit on the extrapulmonary manifestations?
So, sir, starting from the head, we can have seizures, the facial nerve involvement, other cranial neuropathies, serotumor cerebri. We can have peripheral neuropathy, mononeuritis multiplex. Coming to the endocrine system, hypopituitarism, hypercalcemia, and coming to eyes, you can have sclera involvement, and you can have uveitis, sarcoid included, chorioretinitis. In Herford syndrome, you have Sika syndrome, and you have parotitis, parotid enlargement, oral involvement, and then you come down to you can have hoarseness of voice, thyroid mass. Then you come down to the skin. Skin, there is involvement of skin. There is nodular formation, plaque formation, and there is lupus perineo. There can be alopecia in the head. Then you come down to the genitourine, come down to the kidneys. There is renal mass. In liver, there can be granuloma formation, jaundice, cirrhosis. Almost entirety of the body is involved in multiple parts. In psychosocial patient can have anxiety, fatigue, and depression. All these multiple ways of presentation. Sarcoid, as today's presentation, we can say it's a huge mimic. It can mimic like anything, and a skill of a doctor is tested in coming to the diagnosis of sarcoid. I can say that.
Yeah, so very well said, Kumar. I think the skill is put to test whenever we are considering to make a diagnosis of sarcoidosis, and has very well been covered. The symptoms very well explained. I would go from, whenever we are evaluating sarcoid, you go from from head to toe, and then there are different various symptoms that one can come across. And also we recently have also seen somebody with a facial nerve palsy who eventually was turned out to be a sarcoid. So a varied presentations have been very well described by Kumar. So Jay, I'd like to come to you now. In clinical practice, when do you suspect sarcoidosis in a patient?
So basically, very often it is a diagnosis of exclusion, unless, of course, if you have incidental bilateral hilar lymphadenopathy, you might, in an asymptomatic patient, you would think of sarcoidosis. But very often, if you get granulomas, and if you have ruled out any other causes, especially in our setting like tuberculosis, fungal infections. You look for drug exposure. Carefully look out for lymphomas, etc. And all the criteria fit in, of more than one organ involvement, then you would probably think of sarcoidosis. Very often, the clues could be something like erythema nodosum, uveitis, scleritis. These might guide you towards evaluating for the patient for sarcoidosis, provided, we've ruled out active TB as well.
Yeah, so I think, Jay, that is really very well said and summarized. I think we have to suspect sarcoidosis when you have more than one system involvement, and typically when typically I think the patients are seen on a follow-up when things are not falling in place. A typical diagnosis that is made for sarcoidosis TB. Often we see patients who received anti-TB treatment, and then we've seen X-rays worsening, symptoms worsening, and then patients referred, and then eventually, a diagnosis of sarcoid is made. Typically, such individuals may have received empiric anti-TB treatment. Another references that we get from patients are regarding specialty references are typically from ophthalmologists when the uveitis is not settling down, and sometimes now also more and more from the cardiologist also when they have arrhythmias which cannot be explained, or they suspect a granulomatous disease being a cause of the arrhythmia. So I think now that we've discussed the stages, the clinical presentation, the extrapulmonary presentations, when do we suspect a sarcoid? I'd like to move to Dr. Chhabra. Yeah, how can you just briefly tell us, summarize how to confirm diagnosis and which all modalities may be used? I know you referred this to in the lecture, but if you can just tell us, how does one confirm the diagnosis of sarcoid?
The diagnostic area is part of the definition of sarcoidosis, that we need to show that they are non-cation granulomas. So we need tissue for diagnosis. Tissue, as far as pulmonologists are concerned, there are different ways of obtaining the tissue, depending on what is the extent of involvement, where is the involvement, what is the most accessible site. For example, if there is cervical lymphadenopathy, and patients has manifestation within the lungs also, because obtaining a tissue from a cervical lymph node is easier, that is one option. Then if we look at lungs, then depending on where the lesions are, now these days, mediastinal lymphadenopathy is very often sampled by an EBUS. So that is a very convenient tool. Transbronchial lung biopsy, of course, has been a very traditional tool for more than 2 decades for diagnosing, and more recently, cryobiopsy has also been used. BAL is useful in adding to our suspicion because we expect lymphocytosis there, but nothing more beyond that. So essentially, we need to get tissue to show there is non-casing granuloma. There are different invasive tools that I have just enabled. Plus, we have to rule out other causes. So in all tissue that we obtain, especially in our scenario, tuberculosis is always the other great mimic. We call sarcoidosis as the mimic, tuberculosis is the other great mimic. Practically every lesion that is seen in sarcoidosis is also seen in tuberculosis, except that tuberculosis also shows pleural effusion, which is uncommon in sarcoidosis. So tuberculosis has to be ruled out. So every tissue that is taken should be sent for a gene expert, should be put up for culture, and we must be sure that we are not treating an active tuberculosis as sarcoidosis. So that is the most important DD. Plus, lymphomas have to be ruled out. Rarely, fungal infections would cause somewhat similar presentations. So, our diagnostic investigations require a biopsy plus exclusion of other possible common differential diagnoses.
So, thanks a lot, Dr. Chhabra, on that point. And I'm also going through the various questions that we have received linked to this. So, I'll try to take some of those questions here. So, I think, as Dr. Chhabra clearly said, that we have to make an attempt to diagnose, demonstrate non-caseating granulomas. I think that is extremely important. But also remember, along with the demonstration of non-caseating granulomas, the entire clinical scenario is extremely important. We need other features to support that those non-caseating granulomas, which can occur in different clinical settings, are actually most likely due to be because of sarcoidosis. And for that, come to the rescue are the various pulmonary and the extrapulmonary findings. For example, if you have a tissue, a lymph node tissue where you've got a non-Ķ granuloma, that by itself may not be enough. You have to go ahead and look at the other systems. In case you have a lung lesion, you have a mediastinal adenopathy also, and then you want to make a diagnosis, as has been very well demonstrated by the PGI group also. They've done immense amount of work on this. And one of the papers showed that in case you do a lymph node biopsy, plus you do a transbronchial lung biopsy, and both of these biopsies show that there is a non-Ķ granuloma, then that makes the diagnosis of sarcoidosis stronger. The reason I put this up in the discussion is because a lot of the some of the questions are related to that. Also, there is a question relating to the BAL. Sir, as sir said, the lymphocytosis is very important. Very important here is that the patient have to be treatment naive, steroid naive when you do these patients. And therefore, because the minute you might give the steroids, it could affect the differential cell count of the lung. And also, if you have the possibility of having a CD4-CD8 ratio, a CD4-CD8 ratio of 3.5 has got a very high specificity. So I think that was just to add, and I wanted to just cover up some of the questions that have come on. Now let's move on to the next thing. We've discussed several things about the radiological aspects, the diagnostic criteria, the modalities. An important modality, I think, which I would like to discuss is about, and I would like to ask Indranil is, should PET-CT be done in all patients with sarcoidosis? And when should
So Prashant, we lost you?
Yeah?
So,
no, I'm there. I'm very much there.
Okay,
Briefly.
So thank you, Prashant, for just asking this question. So yes, this FDG PET-CT is not included in the standard workup for sarcoid is true, but it's a very sensitive for assessing the inflammatory activity of sarcoid. So there has been growing evidence that it supports the value in the diagnosis and the management, especially for detecting granuloma, the treatment response, the disease extent, some occult diseases, and mainly for the cardiac and the osseous sarcoidosis, and also the place where from biopsy can be taken. So the advantage is that it can identify the ongoing inflammation. So that's the beauty of it, I think. So it is not practically done in every, and it is not included in the standard workup, as I think.
Yeah, so I think, as you rightly said, the PET-CT is not a part of the standard workup. We have a growing body of evidence about the utility of PET-CT in selected conditions when a sarcoid may be suspected or there is an evaluation of adenopathy. And I think the PET-CT, which we use in clinical practice, typically is to sometimes identify the easiest site of biopsy, when particularly an invasive site of biopsy may be slightly higher risk than other places. Because if, often we picked up cervical nodes also, which can be biopsied and can be, they are picked up by the PET-CT. There's also a growing body of evidence for the role of PET-CT in cardiac sarcoidosis. So, it can demonstrate activity in patients with cardiac sarcoidosis. And one thing that has not been discussed is there's also growing evidence about the role of cardiac MRI. So all these are cardiac MRI and PET-CT are used in selected cases and may have a role in the diagnosis in selected patients from time to time. Now I'd like to come to Dr. Varuna. Varuna, I alluded to some of the points from the diagnostic point of view, but I would really appreciate if you could just cover the role of lymph node biopsy, EBUS TBNA, lung biopsy, and the BAL in the diagnosis of sarcoid, and whether they have any role in the monitoring of sarcoid.
Yes. So starting, I would be start with the BAL. It is done in mostly of the patients. First, the importance is to exclude other diseases. Second, as we have discussed, that CD4-CD8 ratio of more than 3.5 we get in sarcoidosis. with the lymphocytes of more than 16%. And it has been studied that the patients with the CD4, CD8 more than 3.5, lymphocytes more than 16, and with the biopsy, if three are combined, there is a 100% of positive predictive value. And if the CD4, CD8 ratio is less than 1, then we have a 100% negative predictive value. So importance of BAL is there. Then second is the conventional TBNA. Most of the centers still don't have EBUS. Then conventional TBNA is also very good in a diagnostic yield. And if we are privileged with the ROSE facility, that is rapid onset evaluation with the TBNA slides, it is pathologists say that if there is a granuloma, then it's well enough that we don't proceed further and risk the patient for the biopsy. Third is the EBUS, which has a diagnostic yield of around 80 to 90%. It is well and good. And again, with the ROSE present, it has more importance in yield and biopsy can be avoided. Last, the biopsy, that is transbronchial and the endobronchial biopsy. Starting with the endobronchial biopsy, as there is an airway hyperreactiveness, there may be presence of erythema, nodules, cobblestone appearance, or even if the patient who is not giving consent for transbronchial biopsy in the view of pneumothorax risk, we can go for an endobronchial biopsy. It also has a very good results. Then transbronchial biopsy in the patients who have, it is important when there is a lung parenchymal involvement, then it has the importance of transbronchial biopsy with a yield of around 90%. And now we have cryobiopsy of the lymph node, then followed by the needle aspiration and the transbronchial biopsy by the cryo. So it all also depends upon the rapid onset evaluation. If we have a ROSE, then it's better for a BAL and a TBNA or EBUS. If we don't have a ROSE privilege on the facility, then we can go with the BAL, TBNA, and the biopsy to confirm the diagnosis in the one setting.
So, taking into account that, ROSE is not so easily available, you mentioned so many, tests, including cryobiopsies and all. But, I mean, can you just tell us what are the basic initial, important steps? Because there is also, I mean, what's the basic approach, initial approach? And I think if the initial approach is not suitable, we can go for the more invasive test. Can you please just give your view on that?
Yeah, it is very important. It is on the what we have and what the person is in expertise. It's all on the facility which are available. If we have TBNA, the BAL and the conventional TBNA is well and good enough, and plus minus with the biopsy. And if you have a privilege of EBUS, then BAL and EBUS is also sufficient.
Perfect. And there was this paper from PGI said that even if you do, correct me if I'm wrong, that even if you combine a transbronchial biopsy, also when the lung is not showing any infiltrates, if you take a biopsy and if you do a transbronchial biopsy and you combine that and that shows granulomas, that strengthens the diagnosis. So there's also one question about, if a patient is asymptomatic mediastinal adenopathy, shall we go ahead and with the diagnosis with biopsy? So would you do a biopsy in somebody? So the question is, shall we do a biopsy in an individual who is asymptomatic and mediastinal adenopathy has been just picked up on routine evaluation? What would you do?
Yes, we should go for a biopsy as it's an Indian epidemic. There is a high risk of TB. So we have to confirm that whether it's a TB or a sarcoid. First, the diagnosis confirm, then we decide for that the patient has to be treated or not. As patient is asymptomatic, diagnosed with sarcoid, then no treatment. But the biopsy is required with the hilar lymph node also.
Perfect. Thanks a lot. Thank you very much. Yes.
Not only tuberculosis, but
other diseases also.
Lymphoma is another important which if we are not picking up, the patient may die out.
So, absolutely. So I think it's important. I think the message is very clear. If there is adenopathy in a country like India, we need to make a diagnosis, and then once you have some histopath, we can take it clinically ahead, whether it is relevant to treat or not. There's one more important diagnosis. I think a clinical setting where we often come across non-Ksing granulomas is, and that is a sarcoid-like reaction or a granulomatous reaction to malignancy, which is not only limited to lymphoma. So often you may have situations where patients have different, have malignancies. Patients are referred to me often for a for enlarged adenopathy, and often we just see non-Ksn granulomas, and that we often label based in several of them as a sarcoid reaction or a granulomatous reaction to malignancy. And that is also very well known. So, I think in the you referred to TB. Now, what is the role of the Mantoux test in the sarcoidosis? So where is it placed in the evaluation of a sarcoid patient? The question is to Dr. Kumar.
So Mantoux test, sir, you are asking about in sarcoidosis?
Yeah. What's the role? Where is it?
Yeah. So Mantoux test is basically having a negative prognostic value. So a Mantoux test is negative, generally negative in sarcoidosis. It's used to differentiate between TB and sarcoid, as both are granuloma forming diseases. But what happens I was going through the questions, how reliable is a negative Mantoux test in tuberculosis or sarcoidosis? So, old timers like Dr. Chavda would know, we used to, old timers used to biopsy the site of a negative Mantoux test and find the non-caseating granulomas from the biopsy site, and that would be one of the pathognomic features in a negative Mantoux test in a sarcoid. So that's what used to happen. In skin biopsies were done from the negative Mantoux site. Generally, sarcoid, we find negative Mantoux test. But to further clarify our point, and the role of 𝐸GRA. So 𝐸GRA has been talked about in sarcoid also, but 𝐸GRA is generally negative in sarcoid patient because there is a negative down regulation of 𝐸GRA receptors and 𝐸GRA formation in sarcoid.
Right. So I think that's very well.
Interferon gamma is down regulated in sarcoid.
Down-regulated sarcoid. Yes. So typically, I think in my practice we look at a negative sarcoid as one of the a negative Mantoux as one of the support for the diagnosis of sarcoidosis. So Jay, now coming to you, I think we've discussed that sarcoidosis can be multi-system, can have varied presentations. What are the clinical mimics of sarcoidosis which often cause a delay in the diagnosis of sarcoidosis?
So, as in our country, very often people are labeled as tuberculosis based on, just the imaging or just the presence of granulomas. And very often people will be on prolonged durations of anti-tuberculosis treatment before they are actually labeled as sarcoidosis. That would be in a way where the diagnosis of sarcoidosis is delayed. But very often we need to be sure that, we are not missing other diagnoses and labeling people as sarcoid and the other diagnoses are missed, like say lymphoma or a careful drug history is not elicited and we are just based on a granuloma, we are just labeling people as sarcoidosis. Even that needs to be avoided. So that those, because those are potentially life-threatening conditions which might be, missed, and if a patient is just labeled as sarcoidosis. Very often there could be, especially radiologically, there could be a similarity between sarcoidosis and hypersensitivity pneumonitis, and both can show granulomas on biopsy, although the granulomas in hypersensitivity are much more ill-formed. So whether there is a trigger factor, etc., we need to look at those as well. So.
Yeah, I think this is a very important point you mentioned, and as Bhavin also showed the triple sign in a patient with sarcoidosis. So I think sarcoidosis can present in many ways and sometimes can be a challenge to all of us clinicians. So thanks a lot. Dr. Chavda, there are certain questions also in the chat box, and many again coming back to the stages of sarcoidosis, and therefore, although it was covered in the lectures, I also had initially started with the discussion of sarcoidosis. Now, coming to the various stages of sarcoidosis, there are many questions regarding what do all patients of stage 1, 2, and 3 need to be treated, or which patients of sarcoidosis should be treated, and which patient of sarcoidosis can be observed. Dr. Chavda, if you could help us with this.
Yeah, this is a very important clinical decision. Firstly, we have to confirm the diagnosis. Even patients who are incidentally picked up that maybe having sarcoidosis like stage 1, we need to confirm that they have sarcoidosis so that we know how we are going to plan the management for this patient now and in future. So that is the first step. Diagnostic confirmation is very important. Secondly, if the patient is asymptomatic, and that usually happens in stage 1, then the option of not treating is there, and it has to be discussed with the patient that this disease has a more than 50% chance of going to spontaneous remission at this stage. So this is the benefit of discussion that we have to give to the patient. And if the patient has symptoms, because symptoms and stages do not always correlate. Higher the stages, so mostly patients with stage 2, 3, 4 would have symptoms. These would impair their quality of life. And greater the impairment of function, greater is the risk of mortality. And that is the basis of treatment. Risk to the patient, mobility, and what is the impact on quality of life. So with these, definitely the patients have to be treated. Having said this, even in patients who have asymptomatic chest involvement, I would still search for extrapulmonary involvement, because sometimes we do pick up cardiac sarcoidosis with asymptomatic lymphadenopathy or uveitis with asymptomatic lymphadenopathy. So the disease is active, if not in lungs, elsewhere. So these patients would also require treatment. So only patients who are not having extrapulmonary sarcoidosis, no symptoms, stage 1, and they are available for follow-up, we can have a follow-up for these patients every 3 monthly, go on repeating their chest exercise till it resolves. Majority of patients in practice do require treatment because they wouldn't come to a doctor if they don't have symptoms.
Right. So that's very well said. So, like, they would come to you only if they have symptoms, and if there are symptoms in sarcoid, and if there's an, excuse me, an organ involvement, one has to treat. But often we are now seeing patients who are asymptomatic, who've undergone health checkups for various reasons, for going overseas or a routine health checkup. We look at adenopathy, and then the adenopathy comes up. And like we discussed, adenopathy has to be investigated. And so there are these situations when we come across adenopathy and you have a non-caseating granuloma, which may be demonstrated. And often we have such patients who are referred for biopsies to us. They come for a EBUS biopsy. Also, I think, like you very rightly said, you have patients with, adenopathy who may have uveitis. So we have the other way around. We have patients, we have some really a good network of ophthalmologists, who would, in certain clinical situations, when they suspect sarcoidosis or a granulomatous condition as a cause of the uveitis, they would do multiple, they would do evaluation scans, have become a routine. And in such cases, if there is, we picked up adenopathy, you diagnose granulomatous adenopathy. So they, in the mediastinum, these patients may be asymptomatic from the pulmonary point of view, but the uveitis becomes the reason to treat. So I think so very well. Thanks, Dr. Chhabra, for this overview about treating. Let's move a little bit further, and now I want to come to Indranil. Indranil, can you just give us an overview about the, and these are also the questions coming in the chat box, an overview about initiation of the treatment for sarcoidosis, how long you treat sarcoidosis, and how do you taper? I know this is a very big question, but I appreciate if you would give us a brief overview on this.
So thank you. And this has already been taken in the presentation of Chhabra sir. So as told, for asymptomatic patient with stage 0, 1 X-ray, they are not likely to benefit. But with mild symptoms such as cough, they can be treated with inhaled corticosteroid. But patients, even who are asymptomatic, but when there is a significant drop in the pulmonary function, they should be considered for therapy. Dyspnea also, again. And as told, corticosteroid remains the initial drug of choice for the treatment of this disease. So to start with, a starting dose of 20 to 40 milligram of prednisolone or is equivalent. And when the steroid has been started, this patient should be followed up, say, in every 1 month or so, depending on the patient condition. The dose can be tapered. So again, how long, it's a real question. So after 3 to 6 months, the dose can be tapered to the physiological level. For example, the 10 milligram of prednisolone per day or equivalent. And if such a taper is not successful, or if there is toxicity, one should consider adding steroid sparing. We have from the armamentarium the steroid spacing, the methotrexate, the azathioprine, and the alternative drugs like the anti-TNF agents may be considered, the infliximab, which is widely used now, or the adalimumab may be effective. So these are the things, but again, the duration may be 6 months from the starting of show, and then we have to follow up to see what is there. And Dr. Chhabra has already presented a flowchart for that. Okay.
Yeah. So Thanks, Indranil, for that. I think you've given an overview about initiation of steroids. And I think how long you give, and then eventually start tapering. I think tapering of the steroids is a very it's a clinical decision. It's looking at the lung function. It's looking at the radiology. So I think once symptomatic benefit has been achieved, a stable state has been achieved from symptoms, a stable state at lung function, a stable state at CT scan, one may consider to taper. So typically when I'm treating a sarcoid, I'm not looking at a complete normalization lung function. A stability of lung function can also be accepted. So now, you also referred to various drugs which can be used as steroid sparing agents. And I would now like to come to Varuna. Varuna, can you just help us with what are the steroid sparing agents which are of your choice, which you use in clinical practice, and what would be a clinical approach towards that?
The steroid sparer drugs mostly used are methotrexate, and another is an azathioprine. I prefer most of the azathioprine, but there are all other drugs available like leflunomide, mycophenolate, and hydroxychloroquine is mostly used in the skin sarcoidosis. There is also available of the TNF-alpha inhibitors, rituximab. The injections are also available, but these are rarely used. If we give the patients a regular continuous treatment with the monitoring, then we hardly go with the rituximab.
Right. So I think that's I think that's a good overview. We've also been using azathioprine for a long time, but now I would tell you a little bit of my change in practices. Typically there's a pulmonary sarcoid. If there is a cutaneous sarcoid, my first choice agent of choice, I've moved to methotrexate, and we've had methotrexate is also giving good results. So I think I agree with you. So methotrexate is my first choice. Azathioprine is next, and then of course that, and slowly also we use a combination of H6 and sometimes mycophenolate also. Yes.
As a part of discussion, sir, what dose of methotrexate do you start and increase to or decrease to?
So that's a very good question. So my it's about 15 milligram is the recommended dose for the sarcoidosis. But I will tell you one thing. I think from experience, it's a one important message. That is, as Dr. Chhabra said, there's no rush about treating sarcoidosis unless you have specific symptoms. So I personally start with 7.5 and then I build up to 15. The reason is that often when I have started upfront 15, we've seen a lot of side effects, particularly hematological side effects. I've seen leukopenia, low platelets sometimes, which you can get, even low hemoglobin, that one can get with methotrexate. So the way I start is, I start with 7.5, I go to 10, I monitor the patients, and then of course you can go up to 15 milligram per week of sarcoidosis.
For the sake of discussion,
yes.
For the sake of discussion and for all our crowds, how often do you monitor? How often do you monitor while giving on methotrexate, sir?
So as far as methotrexate is concerned, I think before we initiate the therapy of methotrexate, a complete evaluation is required. Your routine biochemistry, your CBCs, liver function tests are required. And what I particularly do is that initially, once I've initiated methotrexate, my first set is done typically after 4 weeks. Then the next follow-up is 2 weeks, and then 2 months. And then typically, depending on how I'm escalating the dose, typically on how I see that the CBC is settled, how the creatinine is, how the liver function test is, I will monitor the patient adequately. So I think that's what it is. So that has been my approach. Dr. Chhabra, yourself? Yes.
Just one brief point about dosing, about steroids. There is now a trend to move towards lower doses of steroids.
Yes.
The 2021 guidelines recommend only 20 milligrams of prednisolone.
20 milligrams of steroids. So initially in the past, it was 1 milligram per kilo. Then it came to 0.5 milligram per kilo. And I completely agree with you. Most of the patients I would now initiate on 20 milligram of prednisone. And I'd go further. If I have a patient, we get a lot of opinions. We get a lot of sometimes, patients who are not the first diagnosis, have been diagnosed for a while. I mean, I might also initiate with 10 milligrams sometimes, along with methotrexate. So that's the combination that we would get to.
The trick in managing patients with diabetes is where and how soon do we escalate to methotrexate, and at what time do you plan to start both simultaneously, sir?
Yeah, so typically I would start it upfront when I know that the individual is going to require things. So for me, it's a dual therapy and it's upfront. Yes, Varuna, you raised your hand, please.
Yeah, so I was also mentioning that azathioprine also we start with the lower dose, then increasing it slowly with the monitoring of the electrolytes and the CBC, the liver function test. And what I also mentioned is that it is the dual therapy that work more betterly than especially with the
azathioprine we have particularly used with good experiences in 3 to 5 mg per kg bracket. We give the dosing of azathioprine and with very good results.
Yeah, so I think, to add to that, I think, because of the new guidelines and the new data which has come in, we've moved for the last few years.
Folitrixate has been,
but initially we've been using
second drug of choice after steroids.
Yes, and also I want to say that even as far as the azathioprine is concerned, typically I have not had to go more than 1 milligram per kilo if I need to offer the azathioprine. So 1 milligram per kilo has given a reasonable response. If required, yes, you can extend it to higher doses. And the advantage, one is there's a clinical benefit with 1 milligram per kilo, allows you to reduce the dose of the steroids. And with 1 milligram per kilo, your CBC is also well maintained. So I think fantastic. I'm really grateful to everyone for this discussion. So I think now, Kumar, I'd like to continue with you only. We've discussed various extrapulmonary manifestations. One important extrapulmonary manifestation which you see is hypercalcemia. Every time we are doing a workup for sarcoidosis, we always are looking at serum calcium. We are looking at 24 urinary calcium. Hypercalcemia is important. So, how does one manage hypercalcemia in sarcoidosis?
So this is a very trick question, sir. Hypercalcemia and sarcoidosis, how often do we see, right? It is, the eyes would see what the mind knows, and you would just gloss over things. So hypercalcemia in sarcoidosis is a known entity, and that happens because the 25 OH vitamin D3 changes, converts into active 1,25 OH vitamin D3 active metabolite. So that's how this calcium levels increase. It leads to nephrocalcinosis, calciuria, hypercalcemia. So how do we manage? So generally we have a habit of starting calcium supplements when we give steroids in our ILD patients. So one should be judicious of not putting calcium in sarcoid patients. Or you should have a regular testing of 3 to 6 months, give a low calcium diet, maintain adequate hydration, minimization of exposure to sunlight, and of course 5 to 15 mg of prednisolone is the drug of choice, which will balance your calcium levels also. So these are the things which we do to manage hypercalcemia in patients. And the most important thing is checking your calcium levels every 3 to 6 months.
Yeah, so I think that's a very good overview as far as the hypercalcemia is concerned. Yes, we don't see hypercalcemia very often, but we do see it from time to time. And as Kumar said properly, we have to actually look for hypercalcemia, look for hypercalciuria, and they would find it. Often, one more thing that I monitor in such individuals is the serum creatinine. There's often an intravascular depletion or intravascular depletion, and therefore you have to give the fluids have to be administered. In an acute case of hypercalcemia, is hydration plus calcitonin at least for the first 48 hours. And the creatinine is something important, and you can see the creatinine beautifully coming down once you start treating this, of course, in combination with steroid, calcitonin, and also with hydration. So I think creatinine is also something that one needs to monitor. One more thing, as far as the hypercalcemia is concerned. There is some suggestion in the literature. The literature is not very strong. Often that there may be a risk of hypercalcemia coming back again once you taper treatment. And these are some of those individuals who may need continued immunosuppression in the long term. So these are that segment where one have to be very careful when you taper steroids or taper immunosuppression, and that the calcium levels, etc., need to be monitored in these patients. So fantastic. Thanks a lot, Kumar, for that. And now I come to Jay. Jay, we all discussed about, initiating therapies, monitoring the patients. When does one consider to stop therapy in patients with sarcoidosis?
So if the patient has been clinically stable for at least 6 to 12 months, and on your lung function and radiology, and ideally if it's restricted to lymph node or pulmonary TB, then maybe and if you can have been able to get the patient down to a low steroid dose of say 5 milligram per day, etc., then you might, after counseling the patient, carefully attempt to stop treatment, but look out for relapse carefully with close follow-up, because the highest risk of relapse in such patients is probably within the first year. So have a close follow-up for about 2 to 3 years. Look for relapse in such patients. So stability for about 6 to 12 months, clinically, radiologically, as well as pulmonary function-wise, on a low dose of steroid, and then we might be taking an attempt of stopping that.
Yeah, perfect, Jay. So I completely agree with you. I think, we have to be in this conscious effort of seeing how we can minimize the medications for these individuals. And, typically these individuals may require therapy anywhere from 12 to 14 months for sure. And then, you really need to think about how we can withdraw the therapy for these patients. One important thing, I would like to highlight is, the talking to the patients. Patients have to be told that this is sarcoidosis, this can relapse. Sarcoid is going to stay with you for life. And I think, and that from time to time, a regular monitoring is required, as Jay said, to see whether the sarcoidosis is relapsing again. And one more thing, which I often also encourage is, and I also learned, is that doing a regular lung function test is extremely important. Often we will find that these individuals have an obstructive airway disease component. And if they have this obstructive airway disease component on the lung function test, so then, the one switch that can be made is giving inhaled corticosteroids and trying to reduce the oral corticosteroids or the oral immunosuppression. And often we have several patients who may be fine and may do quite well with the inhaled corticosteroids. So now that we've discussed about how do you taper therapy, we discussed hypercalcemia. Now I would like to come to Dr. Chhabra. So with your experience, can you just tell us, how does one suspect cardiac sarcoidosis, and what would be the treatment approach for cardiac sarcoidosis?
Cardiac sarcoidosis is so something very difficult to diagnose. It's overdiagnosed also, it's underdiagnosed also. And postmortem studies always show that it's a fairly common involvement, more than 25-30%. So that would mean that most of the patients remain asymptomatic. Now, in my practice, what I have seen is a couple of patients who present with syncope. Then palpitations are common. So usually these are the patients where one would be, in any case, as I mentioned, ECG is the minimum test that is to be done in all patients. And sometimes we do pick up too many ectopics or a block somewhere. So that is very useful. Because the major involvement of heart is both muscular, so they are prone to cardiomyopathies, non-ischemic cardiomyopathy, as well as conduction abnormalities, arrhythmias. And these involvements can have other causes also, especially in middle-aged persons. So there's always a suspicion it might be a coronary artery disease. So that also has to be ruled out. So a high degree of suspicion is required, and the diagnostic guidelines of ATS, they say that if you have an ECG abnormal, next thing is to combine it with a Holter and an echocardiogram. And if you have a reasonable suspicion, then go on to imaging. And the recommended imaging now is a cardiac MRI is recommended over PET scan. There was a time when PET scan was given the preference, but MRI is supposed to pick up better. But PET is equally good, and I have seen beautiful focal deposits. Uptakes are there, and these confirm that it is correct. Biopsy is practically never done, and in any case, biopsy is not very specific, not very sensitive also. So with ECG involvement, echo involvement, and a PET scan showing diffuse mottling uptake, one is reasonably sure that it is sarcoidosis of the heart. Now, about treatment, this is one involvement where there's a high risk of mortality. So these patients, besides requiring specific management of their arrhythmias, and these are also candidates for devices. So an ICD is required in these patients. And then these patients require a combination treatment straight away. So steroids plus a second drug like methotrexate continued. And there's very often a lifelong commitment that they have to continue these drugs lifelong. So here we were discussing the question of stopping steroids. Here stopping is a little tricky thing. So generally I've continued with an implanted device, low dose of steroids and sometimes methotrexate forever in these patients.
So perfect. Thanks a lot, Dr. Chabra, with your experience and your explanation. I think that's a lot of value that you have added to this entire discussion. And I completely agree that yes, arrhythmias often, as I said, we have cardiologists who are referring patients to us because they might suspect that the cause of arrhythmia may be the sarcoidosis. So there are two conditions. Allow me to stray away a little bit. Two conditions where we start cardiologists to refer to us for arrhythmias. One is sarcoidosis and other is sleep apnea. So these are the two conditions where our arrhythmia specialists have become very, very conscious and alert, and we see more and more of these patients. So now, after having discussed this, I want to come to Indranil. We've discussed about, treating sarcoid. We discussed about monitoring of the sarcoidosis. How do we prevent relapse? And, in case a relapse happens, how do you treat a relapse?
Okay. Thank you.
You're there?
Important.
Yes.
That's the most important plunge in the management of sarcoidosis. So once you withdraw the anti-inflammatory medication, relapse is there. So if you go through literature, it may range anywhere between 13 to 75% or something like that. And usually it occurs a month or so to a year after you start tapering the dose or discontinuing the dose. Probably diagnosing relapse is also very important. So worsening of the imaging maybe, or the clinical worsening, or when worsening of imaging correlates with the worsening of the pulmonary functions, then you can think of relapse. Another criteria, which question has been asked in the chat box, I have seen about the role of the sachet, serum angiotensin converting, whether an increasing rise of the titer of the sachet may be a sign of relapse or not. That's also another thing which has been well studied. So there are a few risk factors also for relapse when, for example, the addition of a risk factor may be use of steroid therapy for 2 years or long, and then you have stopped the steroid therapy. Patients who have been treated with infliximab may appear to have a higher risk of, likelihood of relapse. So again, the PET scan may be helpful in detecting the inflammatory part or the relapse. And in terms, we have to again restart the same dose of corticosteroid as we have done when we have treated these patients with this sarcoidosis. That may be the option that we have.
Yeah, thanks a lot, Indranil, for that. And, even if you saw in Bhavin's lecture, he showed us, very interesting cases where there's a migration of stages. Initially, you have a dominant of adenopathy, a little bit of parenchymal involvement, and then in the subsequent, a few years later, you see that the adenopathy is regressing, and then you have the pulmonary component increasing, and then subsequently you see the fibrosis setting. So as you very rightly said, I think, yes, our goal, we always hear that, in sarcoid, the treatment can be stopped. We always hear that, we can observe sarcoid, we don't need to treat all sarcoids. But I think it's extremely important that, in patients who are symptomatic, who got end organ involvement, whenever we are tapering the medications, a proper monitoring is required, and also a proper counseling of the patient required, so that if there is any change in symptomatology during the monitoring, it can be identified early and that we can take appropriate steps. So now again, in the discontinued discussion of the relapse, I'd like to come to Varuna. Varuna, what is the role of TN alpha inhibitors or biologics in the treatment of sarcoid? I know you referred that saying that they're not very common, but if you can just expand a little bit about what their role is and how often it is needed in clinical practice.
Okay, the TNF alpha, as we know, it accelerates the inflammation and it helps in the maintenance and the granuloma formation. So the TNF inhibitors are required for that, and it is mostly required when there is a persistent disease, despite the patient being on glucocorticosteroids and to dose mostly more than 15 milligram per kg with the addition of one immunosuppressive agent also. And if these two drugs are failing, then we add on for the TNF alpha inhibitors like infliximab, which can be given at a dose of 3 milligram per kg, and there is a weekly interval of 2, 6, 12 that is to be given. And what we have to other drugs that are also available, like I said, rituximab. And another thing which can be done is we can also monitor the CD4 T cells lymphopenia. If there is a CD4 T cell lymphopenia in a peripheral blood, then the patient will respond to an TNF alpha inhibitors like infliximab. Talking about the clinical scenario, yes, it is very rarely used, and I have still not used it.
Great, great. Thanks a lot, for this overview. And, in interest of time, I'll just speed up because there are many questions in the chat box. We'll try to cover them as much as possible. Kumar, there's a question about non-pharmacological treatment. So can you quickly just, briefly tell us about what is the role of non-pharmacological treatment in sarcoidosis?
So what we are doing in every other disease of respiratory medicine, rehab, a structured rehabilitation program, basically a supervised exercise program along with, psychosocial and psychological support, a diet, a careful diet plan, and a low calcium diet, as I mentioned, will not only improve the quality of life, exercise capacity, and muscle strengthening, because we are putting this patient on long-term steroids of almost 1.5 to 2 years. So that muscle strengthening part has to be taken care of along with exercise capacity. That's what.
Great. And, to that I can ask, I think the vaccinations which we give them.
Vaccination, yes, definitely. Vaccination is very important.
Perfect. Now, quickly, Jay, coming to you, again, can you tell us the clinical presentations which have a good prognosis?
So generally, stage 1 or stage 2 sarcoidosis generally overall have a better long-term prognosis with fewer symptoms at 5 years and lesser mortality. Once it reaches to stage 3 or stage 4, the likelihood of persistent symptoms and mortality both increase. Of course, involvement of the heart, like cardiac sarcoidosis, neurosarcoidosis, obviously alters the prognosis towards unfavorable. And, very mild sarcoidosis, as you can say, maybe just like erythema nodosum or just uveitis would definitely have a much better, or scleritis have a much better prognosis compared to systemic involvement.
No, so perfect. I think you really highlighted it important. I think the areas which have a good prognosis, and I think that's an area where the treatment also can be limited, and we must actively look if you're treating them, then how to withdraw the treatment. Now, a very hot question, which is also there in the chat box. I think for that, I have to come to Dr. Chhabra now. So what is the role of antifibrotics in sarcoidosis?
Well, it's a very difficult question to say yes or no. Right now, we have very little evidence to say that it should be used. The inbuilt study of nintedanib on progressive pulmonary fibrosis, that included only about 10 or 15 patients of sarcoidosis. So it was not powered to show any beneficial effect in sarcoidosis, although in subgroup analysis in that study, they did find that it at least ensured stability. So this disease, sarcoidosis, rarely resembles a UIP picture. So if that is there, which is a very rare presentation, then one would be tempted to use nintedanib. Otherwise, if there is clear evidence that there is a progressive pulmonary fibrosis, so that means a rapid fibrosis within 1 or 2 years of observation, Not that after 20 years there is more fibrosis, you start using antifibrotics. So progressive pulmonary fibrosis has its criteria, clinical, radiological, and physiological. So if that rapid progression is there and there is a picture which is compatible with an IIP, like an NSIP picture or an IPF picture, lots of honeycombing, then there is a reasonable logic to use nintedanib, although there is no evidence to support that. So that is the present position. No clear evidence supporting, but clinical judgment. If one feels that there is a progressive pulmonary fibrosis, go ahead and use, because there is nothing else to offer apart from lung transplantation in these patients.
Right. So perfect. So I think so you've answered several questions from the chat box already. Sir has already told us very well.
One point. Can I?
Yes, please.
So one point I can just talk. Just want to go second to Dr. Chhabra sir. Is there is honeycombing, we have to add antifibrotics. We can simplify it to that. If not anything else, if there is honeycombing, we simply add antifibrotics. Chhabra sir, am I right?
That would be debatable. You know, it's extent of honeycombing plus the additional fibrotic changes that you see. If you just see small area of honeycombing, then it will not be justified to add a drug which is to be given lifelong.
Because I want to add some here. So I think there is a valid point of discussion here about antifibrotics and honeycombing both go hand in hand.
Again,
but I think again what I do is,
I would also
can I just Kumar, just a second, and then So the point I want to add here is that what is important, what I do in my practice, often we get patients who've been diagnosed for sarcoid for a long time. They've got stage 4 things, they've got fibrosis, they are symptomatic. The question here for me is that individual showing clinical stability at that level, not necessarily better, that is the individual clinically stable. Then the role of the serial CT scans. Is there a progression in the fibrosis? I think that's extremely important. I think these are the two important criteria where I would take into account, even in the presence of a traction bronchiectasis or a honeycombing, because if that appears to be stable and non-progressive, then we could do them, with one less drug. And clearly, just to be very clear with the entire audience here, the data is very limited, the data is evolving, and in any case, we use antifibrotics in such patients or in any other patients with ILD where there are no clear-cut recommendations. It's an off-label use, and typically, I personally document that if I use it off-label on the prescription, and we also tell the patients it's an off-label use, but clearly we convey to them that there is a potential benefit, and therefore it is being used in a particular situation. Kumar, back to you.
Thank you, sir. I got the point about it, and I would agree also that the worsening of disease is where, and the serial CT scans are the way to go forward.
Yeah, perfect. Now, we are run out of time, but there are one or two questions which I like to put across, and I would like anybody to take this. Is serum? There's one question here, that in case of if somebody has a BAL, TB, TB gene expert positive and a high serum ACE levels, do you treat for one or do you treat for TB and sarcoidosis? Anybody? Yes, Varuna.
We should treat for a TB first, because starting with the steroids and then would flare up. The sarcoidosis, if not flaring up, not with that stage, treat the TB first. Once the course is done, then take up with the sarcoid.
See, the practice
and one more thing I'd like to add is that in patients with TB also, the ACE levels can be high. So the ACE levels are pretty not. So Dr. Chhabra, you were saying something?
Yeah, see, there was a practice in 20 years back treating both diseases simultaneously, but that is no longer advised. In fact, it is discouraged now. If it is TB, evidence treat tuberculosis first.
Yeah, and I think one of the things is that one of the reasons why ACE is becoming a weak support for the sarcoidosis is that ACE levels can be elevated in any granulomatous condition, including tuberculosis. So I think I agree with the panel that if you have TB, you first treat TB, and then you can take a call whether it has any role at all, if any, later on once the anti-TB treatment is done. So I think, we've managed to cover a lot of these questions. I'm sorry if we missed on a couple of questions, and I think we've exceeded our time substantially. I don't want to hold our seniors and the August panel back, for more than this. We've had more than 2 hours of this fantastic webinar and discussion. I'm really grateful to the entire panel and the speakers for the lovely teaching I've had today so I think I learned a lot. I want to, at the outset, thank the panelists, the speakers, the Indian Chess Society, and there's Sandeep Salvi, there's Amita, there's Rajadhar, we've got Indranil here as a representative also, and of all, Sipla and Harshal for making this possible and taking this to the entire audience all across. And what I just understand is that even as we finish now, Harshal has updated us that we've got 1742 participants who are live right now. So thank you very much. It's been an immense learning session for me. Thank you very much, all of you.
Thank you, Dr. Prashant, and all the panelists. Thank you. It was a pleasure.
Prashant, sir.
Thank you.
Thank you, Prashant sir. Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you to Amita madam and to the whole Sipla team and ICS platform for this opportunity and creating such educative webinars. Thank you so much.
Yes, thanks, Amita, for the invite.
Okay. On behalf